Hello, everyone. Thank you for your patience as we get everything organized. You will hear briefly, in a moment, how many people we have to wrangle for today's presentation, so you will understand. My name is Matt Shepard, and I'm going to handle the technical side of things today. I want to thank everyone for joining us, and I want to thank our, as noted, many presenters. We have, please, I hope I don't forget anybody, Center for Medicare Advocacy Executive Director Judith Stein, Michael Benvenuto from Vermont Legal Aid, Suzanne Bachman and Lou Costanzo, the National Multiple Sclerosis Society, Lynn Brillmeyer, IEE Brain, Sam Porritt of Falling Forward, Cindy Kraft of K&K Healthcare Solutions, Dennis Knopf, Pinnacle Senior Care, Renee Kender, Broad River Rehab, Ellen Strunk, Rehab Resources and Consulting, John Marmaru of 810 MS Specialty Center by Video, and Kathy Holt, Toby Edelman, and Ali Bears from the Center for Medicare Advocacy. Whew. So, as you can guess from that list, we are coming to you live from many, many locations. So do bear with us during transitions as we pull cameras up and down, and so on. Now, if we could move on to the next slide, I can give you a little bit about the Center for Medicare Advocacy before we begin. The Center is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities. The Center focuses on the needs of people with longer-term and chronic conditions, obviously, given why we're here, with work including legal assistance, advocacy, education, analysis, policy initiatives, and litigation. And all of that systemic advocacy that we talk about is based on the experiences of the real people that contact the center every day. I would also like to take a moment, if we can move to our next slide, to thank all the sponsors of the 2023 National Voices of Medicare Summit and Senator Jay Rockefeller Lecture, where we discussed many of the ideas that led to the convening of today's symposium. Make a note, we have the 2024 summit coming up in April, so keep a lookout for a save the date for that. Before I bring up Judy, I do have to do a little bit of housekeeping regarding the GoToWebinar system that we're using today. It is a little more complicated than some systems. I know a lot of people on here have used it before, which is fantastic. Thank you for joining us for our presentations. If you can hear me, great, good start. You've logged into the webinar, you've dialed in by phone, you've got good quality working speakers on your computer, which is usually the case nowadays. If you are certain that your speakers and mic work, we'll be able to hear you when we stop for questions. If you're not certain that your speakers and mic work, you can always dial in by phone using that number that was provided on your confirmation email. That number is also available on your control panel that should be somewhere on your screen under the tab that says audio. You can always switch to phone call, dial in, and we'll be able to hear you then. If you don't see that control panel anywhere on your screen and are just hearing me and not seeing anything, you won't be able to interact with us today because we won't be able to actually pull you up or down. You do have to log into the whole presentation to be able to interact with us. A couple more details on that control panel that I mentioned, pretty important for today's activities. There are a couple buttons on the side of the panel. There's a little orange arrow that lets you hide the panel so it's not going to be in your way. There's a little square that'll let you watch the presentation in full screen view. And then a little picture of a hand. That's the most important one. That's going to be used to indicate that you have a question. During the speaker's presentations, we're going to keep all of our attendees muted today. When we do stop for questions, you can use that little hand icon to electronically raise your hand, indicating you have something to say, at which point I can unmute you. Of course, we have so many people on today, we're not going to get to everybody and everything. We apologize for that, but we are definitely going to try to leave time for Q&A and discussion. If, as often happens when you raise your little hand and I try to unmute you, the audio doesn't cooperate, know that you can always type into the questions panel on that control panel any question or comment that you might have, and I can try to pass those on to our presenters as well. Finally, while everyone should have gotten a copy of the slides and additional materials for today's presentation, and actually, let me correct myself, you got a copy of the slides, not the additional materials, you can, if those didn't make it to you, or if you want those additional materials, download those right now in the handouts section of the control panel. We have an infographic there on improvement, and we have a summary of Jimmo, FAQs, and CMS materials. All right, I think that is it for me. I'm sorry that was so fast. I hope everybody got at least a little bit of it. If nothing else, remember the electronic hand. And now I will hand things over to Center Executive Director Judith Stein to get us started in earnest.
Thank you, Matt, and thank you all for being with us today. It's quite an honor to be with people from all over the country. As Matt indicated, we have almost 1,000 registrants and people from 49 states in the District of Columbia. It shows how important this topic is to so many of us all over the country. And today we're going to be talking about the Jimmo litigation, the settlement, which is 10 years old, and implementation, which is not what we wish it was, lo these 10 years later. We're going to talk about those first topics myself and with my colleague, co-counsel of the Jimmo case, and the person who represented Miss Jimmo herself, Michael Benvenuto, who's the head of the Elder Law Project at Vermont Legal Aid. We'll then hear from the patient and who are also activists, their perspective. Then we'll hear a perspective about all of this from providers, advocates' perspective. We'll have discussion, and we'll wrap up and try and come to some next steps together, and we will follow up with you. One of the things that's so important for us to note is that we have hundreds of people from all over the country who care enough about the issues presented and not covered by Medicare for people who have longer term and chronic conditions, that they are with us today, and they present all these perspectives. And we want to take, if you will, advantage of this coalition to reiterate what's true, put the lie to myths, and hopefully find action steps so that people can get the care they need and are promised the coverage from Medicare. Next slide, please. So, as an introduction to the Jimmo case, let me start, and then as I mentioned, I'll be joined by Michael Benvenuto from Vermont Legal Aid. We want to think along the way about why we brought the litigation, how it was settled, and that means that CMS is now a partner in making it work, and the implementation that we still want to work on. Next slide, please. So why did we bring litigation? After all, the federal regulations, CFR, Code of Federal Regulations, which is cited here, has said since I began this work at least in 1975, that, quote, restoration potential, that means improvement, is not the deciding factor in determining whether skilled care is required. Even if full recovery or medical improvement is not possible, a patient may need skilled services to prevent deterioration or preserve current capabilities. That should have taken care of it, right? Well, it didn't. The most often heard reason for being denied Medicare coverage for necessary care ordered by a doctor or authorized practitioner was and has been, and I'm afraid still is, that the patient has to improve in order to get Medicare coverage and therefore access to care. We heard that all the time. Since we couldn't make it worse, there came a time when we decided that we ought to take action, and that meant, in this case, to go to court on behalf of people all over the country who are affected by this myth and dangerous barrier to care and Medicare coverage. Next slide, please. So we did go to court, and the name plaintiff, it's called in this case, was Glenda Jimmo, a courageous woman from Vermont who Michael Benvenuto represented, who lived in Lincoln, Vermont, and needed home health care as she had ongoing brittle diabetes and a number of consequences of that condition, which she lived with disabilities for most of her life. She needed Medicare coverage for home health, physical therapy, and other treatments, nursing and home health aides. But because she wasn't improving, she was told that she could not get more Medicare coverage and therefore not access to all the home health care that she needed to remain safe and effective at home. So we proceeded with Ms. Jimmo's assistance as the named plaintiff to bring the case in 2011. Next slide, please. And along with Ms. Jimmo, we sued in the Vermont District Court against the person who was then, and quite a lovely lady, but nonetheless, the Secretary of Health and Human Services for the United States government at the time, Kathleen Sebelius, which oversees the Medicare program. The federal action, this federal case was a class action, which means that we represented all people who were similarly positioned all over the country. That is, that they could not get Medicare coverage for necessary care that had been ordered appropriately by their physician or authorized practitioner, and they met Medicare's coverage criteria for skilled nursing facility, home health, or outpatient therapy care, to some extent, inpatient rehab facilities. We filed this case, as I said, in 2011, and there were 5 named individuals who are along with Ms. Jimmo, and 6 organizations that the court let proceed. They were the National Multiple Sclerosis Society, which I thank for joining us first as plaintiffs, which allowed others to come forward as well to say, wait, our people, our members, the people living with the conditions we represent are also terribly affected by this. The Alzheimer's Association, the National Committee to Preserve Social Security and Medicare, Paralyzed Vets of America, Parkinson's Action Network, which is now the Michael J. Fox Foundation, United Cerebral Palsy, and also the American Medical Rehabilitation Providers Association joined in the original complaint. Next slide, please. So you can see how very, very important this issue is to people with so many conditions and injuries and illnesses who are unable to get Medicare coverage and therefore access to care. So important that for the first time in their lives or in the lives of these organizations, they sued the federal government in court. Now, what does the settlement in the case mean? Well, it took us a couple of years to get to the settlement after a number of motions and work in court. But what the final settlement means is, first and foremost, the government joined us, the Centers for Medicare and Medicaid Services, CMS it's called, which runs the Medicare program, joined us as a partner in a settlement to end this case that was approved by the United States District Court. And the settlement means that Medicare covers services, nursing and therapy, if the care provided is skilled. And in the care settings of nursing homes, skilled nursing facilities, home health setting, outpatient therapy, and to a slightly different extent in inpatient rehab facilities. Next slide, please. What it means is that Medicare coverage does not turn on the presence or absence of the potential for improvement, but rather on the need for skilled care. And that services can be skilled and covered when they're needed to maintain, prevent, or slow decline or deterioration, and when the skills of a professional is needed to provide, and notice this, or supervise the services in order to ensure they are safe and effective. CMS, according to the settlement, revised its Medicare policy manuals in all these care settings: skilled nursing facility, home health, outpatient therapy, and inpatient rehab facilities, in order to recognize the principles that we are discussing here today, and the court approved the settlement. So the manuals, Medicare's own policy manuals, were greatly revised to recognize these principles, and you can find them on our website at medicareadvocacy.org. Next slide, please. What else can we say about the meaning of this case? Well, if skilled care is what's necessary in order to get coverage, what does skilled mean? Well, it means services that are so inherently complex that they must be safely and effective, they must be performed by or under the supervision of professional or technical personnel. And you see if that's in the federal regulations, not just in the policy manual. So that even if an unskilled person could be taught to do some of this care, you can ask, would it be safe and effective if there was no therapist or no nurse overseeing that care and observing and assessing how the patient is doing? The question is, does this patient need such skilled services? A condition that does not ordinarily require skilled services may indeed require the skilled care of a professional because of that individual's special medical condition. It's also true that the care must be documented as provided. Next slide, please. Jimmo applies, as I said, to care regardless of the diagnosis in skilled nursing facility, home health, and outpatient therapy, and skilled maintenance therapies and nursing each are covered by Medicare. For a variety of technical reasons, the inpatient rehab hospital setting, also known as inpatient rehab facility, is slightly different. The standard is slightly different, but a claim for those kinds of services should never be denied because a patient cannot achieve complete independence and self-care or be expected to return to his, her, or their prior level of functioning prior to the illness or injury. Next slide, please. Now, as you know, you have all these slides, and we hope that you'll use them as resource materials. And it's one of the reasons we're providing you with all this cited material. So this part is the lawyer part talking. So here's a section from the Medicare Benefit Policy Manual that is specific to nursing homes, but applies for home health as well. Therapy services in connection with maintenance programs are considered skilled when they are so inherently complex they can be safely and effectively performed only by or under the supervision of a qualified therapist. Such a maintenance program to maintain the patient's current condition or to prevent or slow further decline or deterioration is covered so long as the beneficiary requires skilled care for the program to be safe and effective. That so long as is very important. It means that so long as the benefit is still available to the person, so for 100 days of care per benefit period in a nursing home, ongoing at home, and in outpatient therapy, since as we all know, there's no therapy cap now, that so long as a patient needs these services to be provided by or under the skills of a therapist, they can be covered by Medicare. Next slide, please. Now, nursing is also covered as a skilled service, and maintenance nursing is a Medicare covered service. And Michael will talk more about this, but importantly, observation and assessment of a patient's condition is enumerated in the federal regulations as a skilled service. And whether it's provided by directly all the services or supervised by a nurse so that the nurse comes and makes sure that things are safe and effective, that's covered by the Medicare Benefit Policy Manual. Decisions regarding coverage should turn on whether that skill is needed, not whether the individual is expected to improve. Next slide, please. Here I wanted to point out that it again says that this coverage is available so long as the individual needs those services right there on this slide. And this is from the Medicare Benefit Policy Manual as well. So if they still meet the Medicare coverage criteria and there's a benefit left to them, if you will, that coverage can be available and the care should continue. We know this isn't happening. Next slide, please. Here, importantly, we learn that not only is the care possibly to be provided and covered so long as the patient is meeting the coverage criteria, but in the next slide, please, we learn that the care will be covered even if the individual's condition is terminal. So the fact that a person cannot improve but has not elected hospice care, may have a terminal condition, but needs skilled therapy or nursing to slow decline and then perhaps to maintain, it's still covered by Medicare. So this portion of the Medicare Benefit Policy Manual certainly puts the lie to that person must improve. Even with a terminal illness, coverage under the regular, not hospice benefit may be available. Next slide, please. In this example from the Medicare Benefit Policy Manual, we see that even if care can be taught, as I mentioned earlier, to a caregiver, and we hear this all the time, care, they say, at home is only available to teach the family. Well, there may not be family, there may not be other caregivers, but even if there is, if those caregivers need to have skilled nurse or therapist, in this example, to a nurse to look at a wound that the caregiver is helping with, but the nurse needs to come in to observe and assess to make sure that this condition is not worsening and that the treatment is proceeding as expected. That is a skilled service and could be provided and covered under Medicare. And I often say when people call and been told that there's no skilled service, in a situation such as this, for instance, where there's a wound, is it true that if there's no nursing available that the patient would be okay, that the wound wouldn't be in jeopardy, that therefore the person wouldn't be in jeopardy? Same question can be asked. If there's no therapist available, are we sure that this person's rigidity or ambulation would be safe? And would it be as effective as if there was a skilled therapist providing the care? Those questions should be answered in order to determine whether Medicare coverage is available and care can continue. And now I'd like to introduce Michael Benvenuto, my colleague and lead attorney at the Elder Law Unit at Vermont Legal Aid. Michael?
Thank you, Judy. Does my audio work? Can somebody just confirm that?
Yes, sir. Absolutely.
Thank you. Well, thank you, Judy.
Mind if
Thank
we
you
put
for.
up on camera here, Michael?
Yeah, put my camera up.
You just have to acknowledge that request that just popped up.
Okay, yeah, I see that.
Thank you. Perfect.
So thank you again. Yeah, thank you. As Judy noted, I'm Michael Benvenuto from Vermont Legal Aid. We can go to the next slide. I'm the director of our Elder Law Unit, which includes elder law, but it also includes our Medicare Advocacy Project. And our Medicare Advocacy Project in Vermont, we do Medicare appeals for dual eligible beneficiaries. So dual eligible meaning they're eligible for both Medicaid and Medicare. And in our caseload, Medicaid is already paid for the care. And then we look at that claim and we demand bill the claim to Medicare, and then we handle the appeal in the Medicare appeal system. We've done lots of different cases over the years, but currently our practice focuses on home health cases and skilled nursing cases. And I'm not going to talk about therapy in my next few slides. I want to talk about nursing. We definitely do therapy cases in Vermont, but my experience is that a lot of times the therapy, physical therapy, occupational therapy, they switch the billing to Medicare, and so we see somewhat less of those cases. But it's definitely part of our case, and obviously the Jimmo settlement and the changes relate to therapy. But I want to talk about nursing. So let's go to the next slide. So what I wanted to talk about was Jimmo has had a significant impact on our practice, and it is something we argue in our appeals and we bring up in front of administrative law judges on appeal on a regular basis. And I actually do think the ALJs, the administrative law judges, have actually, over these past 10 years that Judy's talking about, have become more informed about the settlement. Often they're actually knowledgeable about Jimmo and how it may have changed things. And so it is something that we bring up regularly, and I guess we argue with the judges about. I'm not saying they always agree with us, but it's something we're bringing up. But what we bring up is the concept that maintenance nursing is a covered service. Judy hinted at that, but I think that's really a fundamental shift in how CMS thinks about Medicare coverage and how many providers think about Medicare coverage. So that's really what we try to push for in our cases. And we argue maintenance nursing as part of or as an overlay to the need for skilled observation assessment. And that's really the main piece that I want to talk about, which is observation assessment for maintenance to maintain the person's condition, to slow or prevent deterioration. In the Medicare benefit policy manual, or how like the Medicare contractors think about skilled observation, they think of skilled observation of a changing condition for like a limited period of time. And the Medicare benefit policy manual even talks about for 3 weeks or until the person's condition is stabilized. And so we argue based on that manual, but the theory of maintenance is that maintenance can go on indefinitely, and it's not limited in that way. I should also say one clear thing about the settlement agreement. In the settlement agreement, CMS agreed to adopt a maintenance nursing coverage standard. That was the core part of the settlement agreement itself, is CMS agreeing that maintenance nursing is covered. And then it was the implementation of that settlement agreement throughout, as Judy was mentioning, all the revisions to the manuals and the criteria, and it's really the implementation of the maintenance coverage standard that we're still working on today. Let's go to the next slide. So to me, what maintenance nursing means is maintenance nursing is reasonable and necessary based on the potential for complications. What the potential for complications means is that is forward-looking, which is always a core part of our argument, which is to say when the doctor is ordering skilled nursing, they are thinking about the potential for complications over the next month, the next 3 months, over the next 6 months. And that's the basis for ordering nursing to maintain the individual's condition. If the person is having significant complications during the period of time that's being reviewed, we argue that as a changing condition. Then their condition is changing, and they need skilled observation to manage that changing condition. But maintenance nursing covers Medicare will cover maintenance nursing even if there aren't complications based on the potential for them, looking into the future based on their medical history. And so maintenance nursing can be a covered service even for an individual that is found to be chronic or stable when it's required to prevent further deterioration or to slow their further deterioration. We can go to the next slide. As part of the implementation of the settlement agreement that Judy was hinting at, we actually had several years of fighting with them about how they were implementing it, and even went back to court saying that what they had done was inadequate. And as part of that, sort of the compliance with the settlement agreement, we got them to agree to put up FAQs on the CMS website, and they're linked here, and I think they're in the materials otherwise. And one of the questions we asked was, how does the maintenance coverage standard under Jimmo apply to skilled observation assessment? And so that was one of the questions. We wrote the question, so I like the question better than the answer, but we'll go to the next slide where they give us the answer. So I actually do think this is one of the clearest statements from CMS about this. And so it's a long answer here, but what they say in the first sentence is that this is the answer to how maintenance nursing applies. It says it can be a covered service regardless whether there's an expectation of improvement for the nursing care, when it's designed to maintain the patient's current condition or prevent or slow deterioration. So that is a restatement of the same concept from the Medicare benefit policy manual. The second statement here where they talk about how observation assessment applies, that really doesn't directly relate to the maintenance nursing part. So I understand that there's a two-part to this answer. Obviously CMS wrote the answer for us, but I regularly cite this and argue this as part of arguing that CMS adopted a maintenance nursing standard as part of the revisions from the Jimmo settlement. I'm going to only have one or two. Do I have another slide? So what I want to summarize is, so observation assessment, so I want to explain just the difference. Observation assessment under the maintenance nursing standard is covered for as long as the individual needs that care. And the potential for complications, when we argue this, means the person is not stabilized. The CMS and the contractors love to conclude that people are stable and therefore that it's not covered by Medicare. But if there is a potential for complications, and that's reasonable for the physician to be concerned about the potential for complications based on the medical record, then maintenance nursing can be covered. And as a core idea, beneficiaries, like, and Ms. Jimmo is a good example. We have many cases like this, where an individual may have 3 months, 6 months, even a year in which they're doing relatively well, meaning they are not having major life-threatening complications or hospitalizations during that period of time. But they should not lose Medicare coverage for that care that they are receiving during that time that is helping them do well. And so we argue they are entitled to continue that nursing that they're getting that is actually reducing the potential for complications or managing their condition in a way that is actually working for them during that period of time. And so that cover the nursing in order to maintain their condition can be covered under the Jimmo settlement and under the Medicare regulations. So that's really the main part of how we've implemented this in our case practice. I think that's it for me, but so thank you. Do I have anything more?
Thank you so much, Michael, and what an incredible ally and colleague you and Vermont Legal Aid are. Thank you so much. So now let's get to like the heart of how do you summarize all this, and I'll go through a few slides and move on to when it's working and examples from our patient population. So the question to ask is a skilled professional needed to ensure the nursing or therapy is safe and effective? If the answer is yes, whether it's to maintain slow deterioration or to improve, Medicare is coverable. Medicare can be coverable. Is a qualified nurse or therapist needed to provide or supervise the care? If the answer is yes, then Medicare coverage may be available and the patient should have access to that care, regardless of whether the skilled care is needed to improve or maintain or slow deterioration, or if the condition is chronic or stable or plateaued. We hear those rules of thumb, those special little words all the time to deny, and that's not appropriate for determinations of whether coverage is available. Next slide. What is necessary is an individualized assessment of each person's qualification for Medicare and need for the care that is at issue, and a determination of whether skilled nursing care or therapy is reasonable and necessary must be based solely upon the beneficiary's unique conditions and individual needs, without regard to whether the illness or injury is acute, chronic, terminal, or expected to last a long time. This is direct quotation from the federal regulations, and it is applicable to home care as well as to nursing home care. Now I'm going to move through some of the other slides to show you what you have in your materials as resources. Next slide, please. This reminds us that there not should be rules of thumb. You need that individualized assessment to see if someone qualifies for Medicare and access to care. And again, CFR means Code of Federal Regulations. That's right underneath the statute, the Medicare Act. Quote this material so that you can get coverage or the person you're helping can. Next slide, please. Now, Jimmo did also require enhanced documentation requirements. Note that if it is important, and to those providers who are listening, if the original decision order was to provide restorative or improved care to improve the person's condition, but then there's a change and it's to maintain what the person has gained or to slow decline, make sure the order is changed to note that. Document what was done and why. And again, if improvement changes to maintenance, get a new order and make sure you begin to document that. Next slide, please. Now, one of the things that Michael alluded to was that we had to go back to court. And in 2017, the court ordered what's known as a corrective action plan. Very unusual, because the government, the Medicare agency, had in fact not done all that was required by the settlement. So they were required to produce a Jimmo page on the cms.gov, that's their official website, cms.gov, dedicated to the Jimmo settlement. The frequently asked questions, FAQs, that Michael referred to, there's a whole set of them, are on the website at cms.gov. We had a hand in doing those frequently asked questions, but in the end, they got the final say. But look at them, because some of them relate. It's not infrequent when someone we're helping has got an example of a problem that actually under the frequently asked questions is given as a circumstance in which they should get coverage. For instance, a person with Parkinson's disease or a person with a terminal illness. The court specifically approved this corrective action plan, the frequently asked questions, and in addition, what's known as an important message about Jimmo, which is on cms.gov. And it's approved the final wording, which required the government to affirmatively disavow the use of an improvement standard. So let me just read this quote. The Jimmo settlement may reflect a change in practice for those providers and adjudicators and contractors who may have erroneously, wrongly believed that the Medicare program covers nursing and therapy services under these benefits only when a patient is expected to improve. That's not true, and the government insisted it never was. Next slide. This was is on the website. It's required to be on the website. If you print it off the website or send the link to someone who's reviewing the case, you will find that it has the CMS logo at the top. That, I hope, will convince someone to provide the care. This was actually last visited today. This slide wasn't updated to include that language. But the CMS website has been recently redone. If you find an error message, please let us know. They are required by court order to have this language up and the Jimmo page up for evergreen for now on. And it says that the Jimmo settlement is consistent with the Medicare program's regulations. That's very important, that they insist that this was clearly established law. Make sure you note that. Next slide, please. Now, in the next few slides, I just want to show that you have documents that show that the CMS, the Medicare agency, reiterated this in 2017. I just showed you. Here is another time they said Medicare coverage to home health care did not change just because the payment method changed. 2020, next slide. In 2021, they noted that skilled nursing care and skilled therapy services to main function or slow decline are covered and issued this reminder about that per our request. So we've got 2017, 2020, 2021, almost 2022 when this reminder was issued. It's the law. Next page, please. Coverage turns on whether skilled care is required, not improvement. That's the key to Jimmo. This is a long-standing criteria consistent with regulations according to the Medicare agency. It's not just us telling them, it's or telling a contractor or telling a provider. It's the law. Please use these materials to help insist that the person, you or the person you're helping, or the person you're deciding whether you can help, gets Medicare coverage and therefore access to the care that they need. Next slide, please. It's so important because when it works, it makes a big difference for individuals. John Marmaru, whose video you'll see in a minute, shows this. He says one of his patients with MS was severely declining when he met him. Take a look at his progress now. Not only are they keeping him in the community and healthy, but he actually continues to make significant gains. That's sometimes the really great surprise that happens. People are human beings and they don't go up and make improvement and then stop. They might continue to get a little better and hold that improvement if we stick with the care. His progress, this John Ramaru says, would not have been possible without Jimmo. I'm sure that this patient would be at or close to a wheelchair without this ongoing therapy program. Next slide, please. Nonetheless, when we asked in the survey of registrants for this webinar, how have you heard about the Jimmo settlement? Only 24% of people who had heard about it, 24% had not heard about it at all. Only 75% had heard. And the vast majority had heard about it from the Center for Medicare Advocacy, not from the Medicare agency. Still, 46% said that this has very much helped them in their work, in helping others, with families and friends, for themselves, or for a combination of that. So it shows you how very important this is and how we must get the word out and must have CMS help us implement this. Next slide, please. Participant comments. We did receive a lot of important comments from people who registered from this seminar. And we have 4 examples here, but we want you to know that we will be using your comments in the months and year ahead as we honor Jimmo's 10th anniversary and try to re-energize implementation. So we will be using your comments. Thank you for them. Aaron P. from Tennessee said, I am extremely surprised to find out that about this case because it seems to me that Medicare does not care that it happened. Sometimes it seems that way to us too, and we hope that CMS will continue to realize that they are a partner in the Jimmo settlement. From New York, I don't understand why all this time later this is not well known in the physical therapy, speech therapy, also known as speech language pathology, or occupational therapy community. Also from New York, another comment. It's an abomination how minimally the Jimmo decision has impacted care for those in need. And finally, a quote from North Carolina. Russell W. says, for Jimmo to work, there has to be a penalty for it not working. Many health professionals are either unaware or unwilling to provide this care. And we agree, that is, there should be audits about not providing this kind of care. There ought to be quality measures that measure whether you have provided maintenance care. There ought to be incentives in the payment models to show that you as a provider are in fact providing necessary care as anticipated by the Medicare law for people with longer term and chronic conditions. And now I am so honored to be able to move ahead to hear from some of the patient activists who and their perspectives who have used successfully or not the Jimmo principles and are living with long-term and chronic conditions. First, we'll hear from Suzanne Bachman, who is a multiple sclerosis navigator, and her colleague Lou Costanzo, who has multiple sclerosis and is living in a skilled nursing facility. Suzanne and Lou, and then we'll hear from Lynn Brillmeyer, who is living with ALS and also works with IEE Brain as an engineer. Suzanne and Lou, let's start with you and then we'll move on to Lynn. Thank you so much for joining us. You're on mute, I think.
Well, looks like you are muted, Suzanne.
Yep.
And Lou, yep, you're also, there we go, perfect.
I'm not getting any of this.
I can't hear Suzanne either. She's not muted as far as I can see, but I am not hearing her. Apologies, everybody. Welcome to the world of online meetings. promised we could hear Suzanne earlier today.
Might we move to Lynn first, and perhaps you could work with Suzanne in the interim?
I can't really do much live here online with
Yeah,
Suzanne in the interim,
okay.
but we could certainly start with Lynn, and maybe Suzanne can check in her audio settings whether her microphone is selected or not.
Hey, Lynn, if you don't mind, we would love to hear from you. Living with ALS is, so we know, such a challenge, and tell us a little bit about what your experience has been with Medicare and coverage access to care.
Hi, I'm Lynn Brillmeyer, and I'm in Houston, Texas. And I have ALS, sometimes known as Lou Gehrig disease. In Europe, it's known as motor neuron disease. Unfortunately, it's a progressive disease. And I am now a tetraplegic. That's a quadriplegic with the bonus that I can't move my head either, which means I am homebound. I have a special multidisciplinary clinic that I go to here in Houston, and it is well known within my clinic that it is difficult to get the level of home health care that people like me need. So they actually keep a list of the best home health care providers that they know of. This is a mix of nonprofit and for-profit home health providers. So I am homebound in addition to being paralyzed. And I have a prescription from my doctor for skilled nursing, physical therapy, occupational therapy, and speech therapy to preserve what we can of my function. I've been in home health for about the last 2 years. And in general, it's worked a little bit to keeping my facilities from getting worse. But I've had to fire 2 home health agencies for failing to preserve service. They constantly are reevaluating me and claiming that they don't need to provide service to me personally anymore for a variety of reasons. One, that I'm not improving, and I've used the Center for Medicare Advocacy information to help there, but also because they claim that they have trained my caregivers and they should now provide these services. Even though, as we discussed earlier, my wife and my adult son don't have any training on how to properly stretch my joints. As a result of this, my left arm is pulled out of my right shoulder by a little bit. So I'm constantly being reevaluated by the home health providers, and they drop these little hints like they might drop me. And then they gradually reduce the amount of service until I fire them. So this whole deal between CMS and Medicare is still a friction point. My current home health provider has told me that Medicare comes into their facility every 30 days and audits a paraplegic they're providing services for. because they don't believe she deserves service. I have a prescription from my doctor for 8 weeks of service, and they're still reevaluating me every month. They claim
Lynn,
Medicare.
I wanna, if you would allow me, just, I don't mean to interrupt, but I think one of the points you made was so important. I'd like to emphasize it, and that is, unfortunately, with deep care, I'm sure, when you, your family members tried to move your arms, they cause damage, and that even though we who don't live with ALS or other such conditions, I think anybody can do that kind of work. It's an example of why it's not safe and effective without a skilled person to help you with that.
That's correct, in my opinion. But what I'm finding here in Houston is the home health agencies don't have employees anymore. It's all outsourced like gig work. And there are
Yes.
these small PT, OT, and ST firms as subcontractors. Whoever is training these people is not explaining the Jimmo scenario to them. And they're constantly telling me that they can stop service without consultation to my physician.
Yes, I'm afraid that people hear that all over, and that again is absolutely not legal. But yes, yet saying that, that's a violation of what is called the conditions of participation to discharge patients without agreement of the ordering doctor or practitioner. It happens, and people like you are left without that care. So I want to, honor your time, all you do to both advocate for people with ALS and other such conditions, and hope that Jimmo and the Center for Medicare Advocacy can help you continue to get at least the best care we can provide while you live with ALS at home. And I hope that home care will be available to you.
A related but different issue is aid services.
Yes,
They're almost impossible to get
yes.
in Houston.
That is also a very closely related and difficult problem. And the Center for Medicare Advocacy is working hard to make sure that home health aides, to try and make sure, are provided as required by the law, and that direct care workers are respected, paid, and trained to provide that care as is supposedly available under Medicare. Thank you so very much, Lynn. We really appreciate you and hope that better days ahead with regard to the care you need. Thank you,
Thank
Lynn.
you for the vine.
Thank you so much. And now I think I'd like to ask if Sam Port can join us. We're having trouble with Lou and Suzanne and their technical difficulties. So we'll move on to you, Sam. Thank you so very much. And in
Judy,
your
hello.
case, Sam, hello, we'll hear a little bit about the value and for you, the way you found this ongoing therapy so necessary and helpful. Sam?
Judy, wonderful to be with you, and thank you so much for including me. I'm really honored to be included. Judy and I worked together on a coalition, and that's how we met. And Judy and Toby and all the members of her team are truly incredible advocates and done so much to help so many people. So thank you again for including me. My story is a little different. And so I am, as the slide says, I'm the founder of an organization called Falling Forward Foundation. And I will tell you about Falling Forward, and it's born out of personal story. Before I even tell you that personal story, I want to give a bit of a caveat. I'm super honored that Judy invited me to participate in this today. also say that I feel like I'm a true outlier, because, and I'll give you the headline, everything worked for me. Like I had an incredible rehab experience, which led me to ultimately founding Falling Forward. So I know I'm an outlier. I know I'm an exception. But I hope that, you know, my story and now the work that we're doing can help and give hope to other people. So next slide, if you would. My story is that my wife and I were on vacation, 2011. My wife and I were on vacation in Italy. I was taking a photograph with my cell phone, like we all do, and suddenly I lose my balance and I fall off a 15-foot wall. And those of you, you know, you're all now listening, you're all knowledgeable about rehab and catastrophic injuries, and you might have already guessed, I had a spinal cord injury after falling off this 15-foot wall. I was paralyzed from like the belly button down. I had no feeling, no movement, and really didn't know what the rest of my life would be like. I had no prior experience with rehab. I knew very little about medicine. I knew virtually nothing about insurance. And suddenly I was needing a lot of healthcare and support and, you know, on this journey of trying to recover from the spinal cord injury. Well, the pictures tell the story. You can see already, you know, I began in a wheelchair. That's actually a photo of my wife and I at the airport in Italy about to come home to America, where I would begin my rehab journey. And I went through, as you can see on the slide, ultimately 2 years of rehab. And the reason for that, you can also see on the slide, is we had this unknown benefit in our insurance policy of having no therapy cap. And therapy caps are a little different than what, you know, we're talking about today. Therapy caps are another barrier, right? The Jimmo settlement broke down a barrier. Well, here's another barrier, the therapy caps. Virtually all health insurance plans, commercial health insurance plans in America, like 98, 99% of them, have this term called a therapy cap that defines how much your insurance company is going to pay for. And they looked at our plan, and out of complete stroke of luck, our plan was one of the very few exception plans that had no cap, which meant I would get all this rehab. And again, all of you on this call are knowledgeable. You know that any kind of neurological injury, spinal cord injury, brain injury, stroke, etc., it's a long, slow recovery process. And again, mine was a 2-year long, slow recovery process, but I got the rehab that I needed because of this fluke in our insurance. And Judy's heard me tell this story at least a half dozen times. You know, during those 2 years that I'm going to therapy and, you know, working hard to improve, every time I'm there, I'm surrounded by people just like me, right? I'm surrounded by people who've all had terrible things happen. Lots of strokes, lots of brain injuries, lots of spinal cord injuries, etc., right? So my injury was no better, worse, easier, harder than anybody else's. The difference was I had this crazy benefit in my insurance policy that no one else had. So I'm going to rehab over and over and over again. And every time I'm there, someone else is dismissed, right? Someone else is told, your insurance runs out this Friday. That'll be your last visit, right? And I kept seeing this happen, right? Like one person after another, their rehab ending because their insurance benefit ran out and they were sent home. And clearly they were being sent home with disabilities that if they had stayed in rehab, if they had a continued course of rehab, it could have made a difference. I want to reflect back on, Judy's comments earlier, explaining the Jimmo settlement. Over and over and over again in the Jimmo settlement and in what Judy talked about, she used the words skilled care, right? Skill makes a difference. Having someone who's trained and knows how to deliver physical therapy or occupational therapy or speech therapy makes a difference. You can't just go home with a black and white sheet of paper and, your therapist say to you, here's some exercises you can do at home. That's not the same thing. It doesn't work, right? I wouldn't have recovered the way I recovered if they had just handed me some exercises and said, go home and do those, right? I needed skilled care and I got skilled care. The sin, the unfortunate reality is so many people don't get skilled care. So that saga, if you will, that those months and months and months of me witnessing other people not getting therapy because of these therapy caps, and I was recovering. I got angry at first. I was angry for a while about this issue, but ultimately, somewhere I had an epiphany and said, instead of being angry about it, do something about it, right? So you can go to the next slide. The do something about it then was founding Falling Forward. So 2 years after my injury, 2013, when I completed my rehab, we launched Falling Forward, right? I was healthy, my life was going on, and I decided, we're going to start this thing called Falling Forward. So in a nutshell, we do two things. Raise money to fund rehab for people after their insurance runs out. And we also do advocacy work, which is why Judy and I met and why we're on this call today. And, we continue to fight on this issue. On the funding of rehab, as the slide shows, we're still a small organization. Although we're 10 years in, it's still, we're still small. So we only work with 4 rehab centers in America. We're proud of the ones we work with. You can see them on the slide. Many of you probably know Craig Hospital in Denver and Shirley Ryan Ability Lab in Chicago, right? They're nationally known. They're specialty centers that treat, the toughest cases. We also partner with 2 locally. I live in Lawrence, Kansas, so we partner with 2 in the Kansas City area, which are the 2 at the bottom of the slide. So we work with 4 rehab centers. We fund rehab for people at those 4 places when their insurance runs out. And there's no question it works. Every person that we've provided additional rehab for has gotten better somehow. Not necessarily made a full recovery because it's not often realistic for people to make a full recovery, but to have more ability than they would have had when their insurance benefits ran out. And we have, dozens of truly incredible cases. We have videos of those success stories. I'm going to show you soon a link to our website where you can see some of those stories. But the gist of it is there's no question that rehab works. It does. People always get better somehow. They always regain ability that they wouldn't have otherwise had as long as rehab keeps going. But we as a community on this call today and the coalition that Judy and I work with and others, our challenge is to keep fighting for that, right? Keep fighting to break down the barriers. CMA has done amazing work, and breaking down the Jimmo barrier was huge. This therapy gap barrier, we're still fighting on. I'll proudly say, I don't have a slide to talk about our advocacy work, but just I'm going to give you a verbal here. I'll proudly say that the advocacy work has made a difference. With the help of Judy and CMA and our other partners in the Coalition to Preserve Rehab and other partners like all the professional organizations in the rehab space, and all the advocacy work that we've together done on this issue, in 2018, we finally had a breakthrough. So in 2018, as I think most of you know, the Medicare legislation was changed. These therapy caps began in Medicare in 1997. So from 1997 until 2018, when we finally got some progress and got them changed. Now in Medicare, there is not a therapy cap. That's the good news. And in Medicare, there's no longer the Jimmo barrier that we're all talking about today. But the challenge is the rest of the population, right? The people who aren't on Medicare, many people who run into this barrier of therapy caps. We're not going to give up. We're going to keep fighting and try to make change on that, because we know rehab works. We know people's quality of life could be better if they get the rehab they deserve. And that's what we're all about. That's our mission. You can jump to my next slide, which I believe is questions. Yeah, we'll take questions here. And Judy, if you want to join me, I'd be delighted. Yeah.
Yes, thank you.
If you don't mind leaving up that prior one that gives contact info while we're talking, that'd be great.
Yes,
Thanks.
I want to thank Sam, and I wish it was true that in practice there were no therapy caps, and in practice the Jimmo barrier was gone. But what we need to know is that this coalition needs to make sure that we keep saying loudly and clearly the Jimmo barrier is gone, and there are no therapy caps for outpatient therapy. In the interest of giving time for Lou to speak, I'm going to ask your indulgence, Sam, and we're going to go right ahead to Suzanne and Lou, who are now available to us. I thank you so much for your work and bless your recovery and that you've turned it into action for others. Thank you so very much. And we have work to do ahead together.
We do indeed. Judy, thank you. And thank you to everybody in your audience here today. My pleasure.
Thank you, Sam. Suzanne and Lou, thank you. I think we can see you now. Can we hear you?
Hello?
We can hear Lou.
Can you hear me?
We can hear everybody.
Okay, go ahead.
All right. Hi. Thank you. I'm Suzanne Bachman. I'm with the National Multiple Sclerosis Society, and I'm an MS navigator. And Lou Costanzo is one of my clients that I've been working with for the past year and a half. Lou lives with multiple sclerosis. And Lou, how long ago were you diagnosed with MS?
It was 2001, just before the planes hit the Trade Center in New York. 2001.
Okay, so you've lived with MS for about 22 years. And then I think you've told me that you have secondary progressive MS?
Yes.
Okay. Originally you had the relapse remitting, and then through the course of the disease, which is progressive, you then now are considered secondary progressive MS.
Right.
And when you have secondary progressive MS, you really need physical therapy, don't you?
In a bad way.
In a bad way. Yeah, I recall when you told me kind of the challenges that you were having in transferring, at the time that you were transferring. Can you tell everybody a little bit about what it's like back then? And this wasn't too long ago, but where you're on your toes.
Yeah, I couldn't stand on my own. And in therapy, they try to get me standing up, but I was standing on my toes, and it didn't go well. After a couple weeks of that, they said, "Well, we don't see any improvement in you, Lou. The insurance company's going to stop paying for my occupational
Your physical therapy, yeah. And at the time, I believe you had both original Medicare and a Medigap policy.
Right.
Right. Okay. Yeah. And what Lou had described for me was that when he was trying to do the transfers, he's on his toes. So what does that mean? That means when you have MS, that ankle weakness had already set in, some spasticity, some foot drop. You have foot drop, Lou?
Sure, sure.
Yeah, and then, Lou believed that he was starting to have contractures set into his ankles, which is really common with MS. And that's precisely why it needs, and it's critically important to have physical therapy and maintenance physical therapy when
Yes.
you live with secondary progressive MS, right?
Right.
Right, and it's maintenance, and it's also to prevent, or slow the decline, because MS is progressive and those contractures can get worse. So I was
Right.
very concerned when Lou told me this, and he said he can't be flat-footed. Well, if you can't be flat-footed and you have balance problems, right, Lou?
Right.
Yeah.
I'm in a wheelchair.
Yeah, well, now you're in a wheelchair, yeah, and so it causes problems and problems with standing, and certainly problems, not being able to walk, etc. So I had been told and contacted by his sister, who said that, originally when Lou moved into the nursing home in a long-term care bed, that he was receiving physical therapy and they discontinued it.
Right.
And both Lou and his sister were really concerned, like, why did this happen? His sister told me, and Lou told me that just what he said, that he didn't improve.
Right.
Well, that's not the standard. So what I did is I self-coached, or I wanted them to do some self-advocacy. So I did some coaching with the sister, Anna. And I explained to her what the Jimmo standard is. I explained it's important as it relates to progressive MS, which she understood. And I told her who to contact within the skilled nursing facility. 10 days later, services were resumed. And Lou, just tell everybody, what is it like when you receive physical therapy? You've been denied and then it's resumed. How does it make you feel?
I it makes me ecstatic that I could go down to the gym and have one of the therapists there work with me, just the two of us, trying to get my feet flatter, and doing maintenance, riding a bike with my hands. That makes me feel better and makes me stronger. Now that only lasted maybe 3 weeks, and I was told that that's as far as the insurance is going, and I was dismissed.
Yeah, and at that time, yeah, it lasted for 5 weeks and they discontinued. But this time, you were told you were doing some work on the standing bars. And as I recall, you told me they said it did not happen.
Right.
Yeah, and what was that it?
I don't know if it was the spasticity in my ankles, my legs didn't go away. I don't, to this day, I'm not sure what it is. But I didn't get any better. I didn't get any worse, but I didn't get any better.
Right, and that's not the standard to get better.
Right.
So, yeah, as I recall, you told me they said that they did all that they could do for you, and it did not get any better. Meaning what? Were you able to stand and stand independently? No.
No.
But what did that imply? That implied that you didn't improve. So this next time around, it was Lou and I that worked together to advocate to again have PT services resumed. So in talking to Lou, I discovered it was the in-house physician who made the original order. And I had difficulties connecting with a myriad of people within the facility to talk about this.
Right.
So Lou and I, remember we conference called Dr. Bromley?
Yeah.
Yep, we made a conference call together and we explained, Lou, described as he did to you all of the difficulties of being on his toes, and then made a request for ongoing maintenance PT. So the fax from the doctor's office arrived in the physical therapy department, but it took 6 weeks before someone from the physical therapy department came to talk to you.
Right.
Yeah, and before that, though, the reason why the person from the physical therapy department talked to you is because your social worker came into your room and I had coached you, this is what you need to say, and Lou pulled it off fantastically. I was so proud of him. And then the social worker talked to the physical therapist, who then about 10 days later came into his room and said, okay, we'll resume PT services. But in her conversation with him, she said, well, what is it that you want from PT? And I was a little concerned that that question was asked by his facility physical therapist, because the physical therapist should have known, right?
Right.
But anyway, it was resumed. And then Lou, this last time around, that was physical therapy last January, the last time you had it. Do you remember how long they provided it when they resumed it the second occasion?
It wasn't that long. My mind isn't sharp as it used to be. It was maybe 3-4 weeks.
Okay, 3 or 4 weeks, and that would probably have put you in the beginning, then end of January, beginning to February, and now it's September, and you have
Right.
not had any physical therapy,
No.
which you need as a person living with MS, right? So
Yes,
Lou,
I do.
could you tell everybody, how does it make you feel when you don't have PT?
It's discouraging. At least when I do have PT, I'm accomplishing something, even if it's uh, staying on the bike for an extra 15 minutes. It's rewarding, I should say, to go to PT and to get any little advantage from it. Now, I'm not saying the advantage lasts forever, but at the time, it was important to me that I made some inroads.
Yeah, and I want to add one more thing real quick, if I can.
Okay, thank you, Suzanne, because I think this is so compelling and telling that it has myriad consequences to the benefit of Lou's life. And you don't have to start running in order to have gained from the PT, and maybe hang on to that and not have to lose what you've gained.
Right.
Suzanne, I'm sorry, did you have one more thing you wanted to say?
Just one more thing, and I think this was
Sure.
important. When I talked to
Absolutely.
Lou about what it meant to him not to receive PT, he said, nobody is to blame but myself. And that broke my heart. And I let Lou know that this is about his rights to access to PT is being denied, and it's not about him, but it's about those who are not providing him the physical therapy that he needs and that he's entitled to.
Exactly, Suzanne. You're so right. And Lou, that has please at least wipe that sense that it's your fault out of your constellation, because it's the fault of a system that isn't working properly. And Sam demonstrated with an injury how ongoing PT rehab had made such a difference. And of course, when you start and stop, you lose, and then you have to start from that place.
Right.
So I'm grateful for your willingness to speak with us about the real life implications of this lack of implementation of the Jimmo case, and that you should be able to get the care you need to maintain what you've gained and hopefully slow deterioration. In a little bit, we'll show a video from a gentleman, John Marmaru, who's a doctor of physical therapy who runs a clinic for people with MS. I'm hoping not too far from you. That might be of value. But thank you, and Suzanne, for the work and for the life you lead. And it's not your fault. Thank you both so very much. And now
Thank you.
hang on and listen to some therapists who do provide this care.
Thank you, Judy.
Thank you both so very much. Thank you, Lou. We honor your participation.
Thank you, Judy, and thank you, Suzanne.
So let's now pull up Cindy Kraft, and Cindy, do you want to, and her panel of therapists. Cindy Kraft is a physical therapist with K&K Healthcare Solutions. She's going to be moderating a panel with Dennis Knopf, who's also a physical therapist from Pinnacle Senior Care, Renee Kinder, a speech-language pathologist from Broad River Rehab, and Ellen Strunk, a physical therapist from Rehab Resources and Consulting. Thank you for the remarkable work you do. I've worked with Cindy quite a bit and with her colleagues, and I'll leave it to you to moderate your fine panel. Thank you so much, Cindy.
Well, before we get started, can you hear me okay, Judy?
Yes, I can.
Okay. I feel like the first in a series of 4 providers that, I want to acknowledge the frustration that I'm hearing in the stories, in the comments to the survey, with the professions I represent of physical therapy, as well as occupational therapy and speech language pathology, that I am as outraged as you are when care is not being provided that the beneficiary is entitled to. As a matter of fact, K&K Healthcare Solutions celebrated our 10-year anniversary this past June, and since day one, we have been committed that a cornerstone of our business is going to be advocacy and education about the provision of maintenance therapy. Because it should not be 10 years later and people claim that they don't understand, or the ones I encounter periodically that are clinicians that say, I do understand, I'm just not going to provide it. I'm not comfortable with it, or I don't want to do it. So I'm not here to defend that, but I want to give those of you that are beneficiaries, those of you that are caregivers and advocates, as well as fellow providers, some context to this issue that I think is a bit bigger than we started the conversation looking at the regulations and the great work that was done to hold CMS accountable that they can't deny solely off of this improvement issue. But there also are other problems that complicate this. If you look at the next slide, I want us to take a moment and think about, what do you imagine when someone says they're going to go get therapy, or they're in the skilled nursing facility and they're getting therapy, or they're in rehab and they're getting therapy, or if you've received therapy? We instinctively connect that to an expectation that someone's going to get better, that therapy is designed to improve your function. That's what they're going to do. You're going to walk better, bathe better, communicate better. That's the stereotypical vision. If you think about any time therapy is represented in media or in TV shows or in movies, it's about working hard and getting better. Well, it's not just that stereotypical view from the beneficiary. The next slide challenges us to say, as a provider, how have I seen myself? And I can tell you that people become therapists because they want to help people. Overwhelmingly, that is the driving force, okay? We get into our respective therapy programs, and from the very beginning, we're told that our job is to improve. We are going to get people better. They are going to be better than when we started. And we start to identify ourselves from the very beginning as that's our job, that's our value, that's the measuring stick. If I can show you are able to do something better, then I have achieved my life goal. And unfortunately, what came along with that, probably somewhat unintended initially, was this idea that if I can't improve you, if we've reached a plateau, if there's nothing else that I can teach or train that will change you, then I'm obligated to stop. This was fueled by CMS, allowing denials to go on for years off of that improvement standard. So yes, the Jimmo decision clarified that wasn't true and never should have been true. But as a provider, if your entire career has been designed around improvement, just saying, well, here's a piece of paper that says that's not true, it can be a seismic shift in how we view our care delivery as clinicians. A seismic one. I'm not saying it's a big enough one that 10 years later it's an excuse to say, I just still don't understand. Okay, you got to grow and move on. But you got to acknowledge that many therapists, if they haven't really spent time understanding this part of the benefit, their reaction may simply be, that's not how this works. That's not how I define myself. It's almost like, imagine that your entire life were told that you were from a certain country. We'll just pick my lineage. You're Dutch, okay? You are Dutch. You have been told you're Dutch since you're little, that you eat the food, you have the flag, you celebrate holidays, you embrace this completely. And then you do one of those ancestry tests that comes back and says, you're not. You're actually Portuguese. What? Excuse me. Hold on. Hold on. That's the equivalent for many clinicians in this space. I've identified myself in a very specific way. Now you're saying that wasn't even true and I need to change. So again, this is not an excuse. This is how we have to think about as we're working collaboratively, providers, beneficiaries, and advocates, to make sure we understand some of that baggage so that we can move forward with things like the next slide to really help us look at this and say, maybe part of the issue is the word. The word maintenance to therapists at times looks like you swore in church. It makes them uncomfortable. I'm not looking for wordsmithing issues, but can really help the conversation when we use the truth, which is a maintenance approach to care is trying to stabilize their functional ability. So if the word is causing an impairment to a progressive conversation, then I think talking about stabilizing function really helps to reframe the conversation. The next slide gives you some insight into how a decision is made. So regardless of whether we think this person is a maintenance candidate or a restorative candidate, therapy always starts with a thorough assessment, gathering all that information about the patient to then say, okay, looking at them now, do I believe that there is an opportunity for material improvement? If I do see that following the bottom trajectory, I still have to determine, do you need the skills of a therapist to accomplish that? If you do, then you're going down a restorative course. If you don't need a therapist, there's nothing for me to teach, train, explain, supervise, modify that's unique to my discipline, then there is no need for therapy. But what about that top trajectory? What if I do my assessment and I look at all things considered and say, looking at you comprehensively, you are at an optimal level of function, that you are about as good as could be expected right now, given all the things going on. My concern is, can you stay there? Can we stabilize this function? Okay, well, I still have to determine, as Judy has said numerous times already today, do you need a therapist? Do you need skilled care for that to happen? That's the course that gets us to maintenance therapy. But again, if there is nothing for a therapist to contribute, there's nothing to teach, train, supervise, modify, implement, then there is no need for therapy. But you can see on the next slide, this isn't always about, I'm going to start out, do an assessment, and you either go maintenance or you go restorative. What we often see is a movement between these two. So the patient starts out, and we do really think that they have the ability to improve, and we provide skilled care to accomplish that. But over the course of care, for some beneficiaries, we realize that what we've gained, what we've improved, is not necessarily sustainable without continued involvement of a therapist. So they've plateaued, they've reached these milestones, but I'm concerned that they need skilled care to make sure that plateau is stable. That's where we see that transition from a restorative focus to a maintenance focus of care. And as Judy pointed out, fellow providers, when we follow that path, we have to make sure our orders are clear and our plan of care is modified to say, I am making this kind of a shift. My final slide is really a call to action, and you're going to hear stories from the next three folks on this panel about the application of maintenance therapy in their setting. But I believe, as a provider, that this whole I don't do it, I don't understand it has to stop. Any therapist can decide that they are not going to provide maintenance therapy. Technically, don't come back on Judy and yell at me. Technically, I can decide I'm not going to provide that. What it doesn't absolve me from is I am still accountable to the Medicare benefit and to the beneficiary to be aware of those criteria, those expectations. So even if I say I don't provide it, I need to know when the person in front of me would benefit and qualify from this level of care. And if I don't provide it, find them somebody who does. Let them pursue someone else that does. I don't get to say, because I don't provide maintenance physical therapy, you can't have any. Well, I don't provide it, but I need to know where to send you when you need it. I don't get to cut that part out of the benefit completely. So let's turn it over now to the next panelist, Dennis Knopf, and he's going to share his experience from a home health perspective.
Thank you, Cindy. And it really is a great experience with Jimmo on balance. If you can move to my next slide. Pinnacle Senior Care is not a huge home health organization, but it is in 8 states and working primarily with the highest acuity and most expensive patients. One of the big frustrations that our therapists had always had was, after 3 visits where people weren't improving, we were always told, you must discharge. And then when that would happen, then the individual that we had been treating would become injured and we'd see them again. Of course, that injury was going to be very expensive and it was going to cause problems, maybe worse problems than had been experienced previously. So Pinnacle Senior Care, owned by United States Medical Management, it participates in an ACO, Accountable Care Organization, and it was also part of a demonstration project in the early 2010s in the Detroit area. And one of the things that, with this very expensive group of patients, average age of these patients was in the mid-80s, you would find lots of comorbidities, lots of issues, lots of functional difficulties. But what we also discovered was, by the provision of first therapies significantly, home health care significantly, we had a significant reduction in overall cost of the care of that patient. Lower emergency department and hospitalization rates, and that was significant healthcare savings. So from that perspective, our demonstration project was very, very good. We started our maintenance care almost immediately after we heard of the decision. We had a very forward-thinking CEO at that point, and he said, they say it's legal, we need to keep these people safely at their home. And that's been our mantra ever since I was involved with Pinnacle Senior Care. Next slide, please. So lots of things related to the things that Cindy has spoken about previously. Researching the ruling, educating staff, and trying to get, I think we came up in a previous meeting, the term legacy staff. So maybe seasoned professionals, like Cindy mentioned, that had, I've always been told, you have to improve, you have to improve, you have to improve. And if you're not going to, I can't see you as a physical therapist. But we had evidence from all kinds of different organizations. obviously from the Center for Medicare Advocacy. We saw the decision as it came down from Vermont. We had defense statements from the American Physical Therapy Association, the AOTA, the Speech and Language Association, and all of these, if you drip enough water on somebody, hopefully you can make a change and they will understand that this is how we have to do things going forward. So lots of repeat education, but actually one of the best selling points was outcomes. We had people, as I mentioned previously, that would end up in the hospital frequently after they had been discharged. So what would happen if we stayed in and provided maintenance therapy? All of a sudden, these people weren't going back to the hospital. They weren't in the emergency department. We were successful, and the patient was happy. They ultimately, many of them would plateau. We would work with them to maintain their current standard. And then all of a sudden, they started to improve. So just as Judy and Cindy both mentioned, you have to change your orders as a provider. You have to make sure that your plan of care reflects the kind of care that you're giving. But we saw significant improvement in many patients that actually we saw over years in care of between maintenance and restorative therapy. So we were very successful. We were happy. Our patients were happy. They don't like going to the hospital any more than we like to see them go to the hospital. And so one of the things that we really experienced was great success. For the first 5 years of us providing maintenance therapy, there was really no denial for maintenance treatment. The one caveat I would add to that is that perhaps sometimes our documentation wasn't strong enough in those circumstances, and so we would have a denial. But for flat out, hey, you were not going to pay for maintenance therapy, that's not what occurred. Next slide, please. So ultimately, several things. The results for our accountable care organization, it was a win-win all the way around. Medicare found tremendous savings. We work very closely with a physicians group that is affiliated with United States Medical Management, known as Visiting Physicians Association, have recently changed their name to Harmony Cares. But that ACO, that accountable care organization, has been extremely successful, ranked in the top 5 nationally in savings per beneficiary for 4 years running. And how does that happen? Excellent care, really doing the things that are necessary to keep people safely in their home. And a large part of that is maintenance therapy. So that was very, very critical for the success of our accountable care organization. Patient satisfaction, extremely high with the provision of maintenance care. No one wanted to be discharged if they felt that they were going to decline and be left on their own. And then anecdotally, we had many patients who, as I mentioned, had been frequent users of the ED or hospitalized, and they had significantly reduced utilization. And as I mentioned, we saw people for maintenance therapy for years and successfully. Now, the downside. In the recent past, we've experienced some issues with a specific Medicare intermediary that we have tussled with significantly and not necessarily successfully. But we were able to ultimately come back around after a period of time where they were reviewing charts and denying care. But once we got past some of the hoops that they made us jump through, we were able to return. But we have to be extra careful. The other thing that we're seeing is there are some advantage programs that are causing some issues too. They follow the same Medicare rules. They should abide by the Jimmo ruling, but we're finding difficulties there. And as you might imagine, the red tape of trying to get certain companies to change their rules is challenging, to say the least. So on balance, again, we've been very successful with our patients. They've been very pleased with the provision of maintenance care. We've had some frustrations on the payment side, but this thing that I said previously, it's been a win-win-win. We, as a provider, are happy because we're taking good care of our patients. That's why we do what we do. CMS has been happy because we've saved them money, and the patients are very happy with the provision of care. So I will end it there. I know we're kind of running a little bit late, so I'd like to pass off to Renee Kinder, who's Broad River Rehab Executive Vice President of Clinical Services. Renee?
Good afternoon, everyone, and thank you, Dennis, and to the entire team for all of the information presented thus far. To Dennis's comment, we are running a little bit short on time, so I want to be as efficient as possible. Next slide. And I want to speak a bit to the call to action that Kathy presented. When we were speaking as rehab providers and preparing for today's presentation, what I've seen in a positive way when it comes to the settlement, the information that's been provided on the CMS website, all of the advocacy from the Center for Medicare Advocacy is that when you train your therapist as part of new hire orientation and onboarding, that this is not a level of care that is specific or special in only certain situations, but this is an absolute, that we provide really 2 tiers of therapy. The first being rehab therapy. This is often what we are mostly trained on as undergrads and graduates. And then we can go on to the next slide. But it is of equal importance to maintenance therapy and giving them the definitions, giving them the regulatory language, but also to a point that Dennis made, sharing with them the evidence-based practice guidelines. Because when it comes to what Judy let us in with, and that's the definition of skill, our therapists are trained that they have to adhere to evidence-based practice. They have to look to guidance from APTA, AOTA, and ASHA, and they have to be able to provide a level of care that is complex and sophisticated in nature. We can go on to the next slide. And I want to touch on that complex and sophisticated piece next, because maintenance can be complicated for therapists to wrap their head around. We know, to the last bullet on this slide, that maintenance can be performed to maintain and to prevent slower decline. So as a call to action, I think there's a level of accountability for payers, but also for us as therapists to do our due diligence when it comes to the care that we provide, that it's following evidence-based practice, and that we're documenting accordingly. So when we talk about skill, but the patient might also decline, but we're slowing the decline, that's complicated to navigate. So some tips when educating your therapist: ask them what they did during care. Because what we often find in therapist documentation is that therapists want to talk about the patient. We all got into this industry because we are caregivers and we want to care for folks. So therapists will talk about the patient. What I need you to talk about in rehab therapy and maintenance therapy is you as the therapist. What did you do, even if the patient is maintaining function, to alter, adjust, modify, tweak, train, all of those skilled buzzwords? So effectively, we're doing our due diligence and our documentation. So when it comes to the payer perspective, when they review our care, they say, oh, that's skilled. There's no one else that could have provided that level of complexity and sophistication. Let's go to the next slide. Improvement standard we've already covered. Let's go on to the next slide. And I'll give you some guidance on a couple of the top questions usually I get in training. So one is, are professional therapy services available under Medicare only for patients who are improving? We all know that the answer to that is no. We also know that this is applicable for various areas of Medicare. So personally, I work in skilled nursing facilities, but that includes the Medicare Part A and the Medicare Part B benefit. So there are some myths out there in the industry that, for example, maintenance is only covered by Medicare Part B. So it's important for therapists to know, and I know there's been significant advocacy to ensure that all of those settings are meeting the criteria. Next slide. Definition of skilled care, we don't need this one because Judy nailed it at the beginning of the presentation. And then the final piece, what qualifies a patient for therapist provided maintenance services. And this is where that call to action given and the accountability on the therapist part comes into play, making sure that we are adhering to all of the guidance within. I look at Medicare Benefit Policy Manual essentially is the gold standard, ensuring that we are meeting all of the thorough assessment pieces, which may include looking at baseline and prior level, looking at standardized testing, ensuring that we are collaborating with the physician and the other interdisciplinary team members, and documenting in a way and writing our goals in a way that we can show that daily skill, we can show what is unique and complex about the services that we provide. And at the end of the day, we can ensure that everyone that we care for is able to maintain that highest practicable level of function for as long as possible. And I'm going to turn it over to my friend and colleague, Ellen Strunk of Rehab Resources and Consulting.
Thank you, Renee. I appreciate it. Can everybody hear me okay? I will assume you can.
Yes.
Yes, sorry.
Fantastic.
Yes.
Thank you, Judy. No worries, no worries. Just want to be sure. So thank you. I will also be brief. I think a lot of the most important points have been discussed, but if we want to move on to the next slide. You know, in preparing for today's conversation, our group talked a lot about the reasons why it hasn't gained maintenance hasn't gained traction in the last 10 years. And so in looking at it from the SNF perspective, I asked myself, you know, why is this care important? What are the opportunities available and what are the challenges? And I think the why this is so important has been discussed very eloquently by those before me, including those patients who, thank you for joining us today, have had firsthand experience. So I'm going to start with opportunities. Many of us are aware that CMS is moving further and further down the road of value-based payment systems. Dennis alluded to this. This makes sense. Who wants to pay for a service of low quality or that, you know, we don't find is worth our money? So Medicare and other payers are that same way. They're moving there. And since my role is to focus on SNF, I'm going to address the value-based systems in the SNF. The SNF value-based purchasing program is maturing quickly, and in this year's rule, 2 additional measures were adopted. The long stay version of the falls with major injury measure, which means this measure is including long stay residents too. Another measure is the number of hospitalizations per 1,000 long stay resident days. So a SNF's Part A payment is going to be, you know, bonused or penalized based on not just the patients in the short stay population, but long stay as well. And CMS did this because they recognize the quality of care in a SNF extends to all patients, not just the short stay population. So I think it's really important that SNFs begin to think about this as they prepare for a VBP that matters. And as a therapist advocate, I think that we as therapists need to be involved in that conversation. We can be a part of the value solution. We have a role. We do not need to walk away from that role of preventing falls and preventing rehospitalizations. The same is true for patients in skilled nursing facilities using institutional special needs plans or ISNPs. Dennis alluded to this in his mention of the ACO that they work with. Many of these models are managed slightly differently, maybe locally, maybe nationally, but they all have the same goals. Help patients age in place, keep them healthy, and keep them active. And Cindy alluded to this in her comments, but therapists and SNFs are sometimes, I think, more focused on short-term patients because it's easier to see that change. We want you to walk out of here, and that means success for us. But in the SNF, we have a population that is not going to leave the facility. These patients are different and have different needs. And we cannot forget those patients who will make smaller changes or for whom that the goal is not to see a change at all. We don't want them to have a fall. We don't want them to have weight loss. We don't want them to be sent back to the hospital. So it's imperative that we take a serious look at our long-term patients and then identify those for which maintenance therapy might be appropriate. You know, I believe that nursing homes should have a culture of mobility and movement, and we are that champion. So moving on to the next slide, what are the challenges? Well, I think the previous speakers have spoken a lot to that. You know, many therapists just don't understand maintenance therapy. They're unaware of it. I think a lot more education is needed both in the schools and in onboarding with new therapists. In fact, if every skilled nursing facility could onboard every clinician, nurses and therapists that they hire in maintenance therapy, we might be further along. But I also want to clarify that maintenance is not a replacement of restorative nursing in a SNF. We can't confuse the two, but maintenance and restorative could exist side by side. The need for skilled maintenance is patient specific and not condition or diagnosis. You know, research tells us that persons who are highly functional, well, and able to perform some or all of their ADLs generally have lower costs of care. So our role is to work at, you know, bending the trajectory of declining function and increasing costs. We know we can't prevent aging, but we want to be sure that we're doing everything we can to mitigate it and keep people in place. And then documentation. We've spent, you know, some time talking about that. I think that, you know, again, it's all about the education, as Renee and Cindy pointed to. I think it's also that something as therapists in leadership roles need to solve for, right? We can work with electronic health record companies to change templates, to provide language that supports therapists in documenting maintenance therapy, because the need for strong documentation is real. In a value-based world, you know, where outcomes matter to how much you get paid, you better believe that we want the story to be told that skilled rehab and skilled maintenance both matter. So on the next slide, just to summarize, you know, we have a very important role. That role is to strike the balance. It's not easy. We're equipped to make those decisions though. What we don't want to do is miss an opportunity to identify and provide maintenance therapy. You know, we all worry about, will this be paid for? Will the payer deny this after the fact? But the takeaway is this: our decision-making and our description of those skilled services is our responsibility and our skill set. The burden should not fall on the patient who would benefit from those services. And as Judy and Sam pointed out, when we encounter system issues such as payers that prevent us from doing this, we need to make a lot of noise. So now I'd like to welcome Cindy and Dennis and Renee back on screen. I don't know if we have additional time for discussion, but I will leave that to Judy and Matthew to determine.
Thanks, Ellen. Judy, I think, do we want to postpone Q&A and discussion if people can stick around a little bit, or do we want to take a couple now?
Yeah, what I think we'd like to do, if you all don't mind, is to look at the video that we have of John Marmaru's PT physical therapy clinic, and then we can move to questions from all of us, advocates and providers, if you can stick around with us, and we'll pull us all up, and if Sam's still available as well, and answer some questions. I think that would be the most interesting and useful piece of time at this point.
That sounds good.
That works. Let's do it. So let's look at the video, and then Matt will call us back up.
Hello, my name is John Marmaru, and I'm speaking with you today from Providence, Rhode Island. My role as Executive Director is both challenging and rewarding. I'm not able to be there with you today because my role as dad requires me to stay close to home. I'm very excited to celebrate and acknowledge the 10-year anniversary of the Jimmo settlement. This clarification happened in 2013. So much has happened since then. Progress in terms of maintenance therapy continues to move forward. This milestone would not be possible without the work and dedication of those at the Center for Medicare Advocacy. In 2008, I shifted my career to focus on those with chronic illness. The challenges that I saw, what needed to be addressed, was how do we as clinicians safely and effectively maintain gains for our patients after skilled intervention is stopped. In my view, the acute care system was doing what it was designed to do. It was doing a good job of stabilizing people from a medical point of view and getting them home safely. But once this occurred, care stopped for those vulnerable populations. There was nowhere for these people to go safely to remain stable and stay in the community. This was a big problem to me. Patients with chronic illness were often receiving care only when they became very ill. This type of episodic care did not make sense to me, and ultimately I viewed it as wasteful and it discouraged the patient. This was when I decided to start treating patients regardless of insurance restrictions. This was very satisfying, but it was difficult. Then the Jimmo ruling happened, and we were very happy. Of course, one reason we were happy is possibly we would be reimbursed for these very necessary services we've been providing for many years. But more importantly, I was happy because the spirit and the substance of the Jimmo ruling directly aligned with our mission. And it made sense. It's what was best for the patient. This is very encouraging to me. Jimmo was a huge victory for so many, and it's changed many lives. Patients with certain conditions cannot safely and effectively maintain gains, period. If Jimmo is not followed, many could have a negative event that will result in a hospitalization. This is a predictable pattern that I've seen for many years. It's upsetting to me because I know it doesn't have to happen. We have to find a way to improve this. The Jimmo ruling is an amazing achievement that would not be possible without the work of the Center for Medicare Advocacy. To my friends and colleagues, for the sake of our patients, we have to keep our eye on the ball. Rather than tell you how Jimmo has changed lives, I thought it would be better if I showed you. Enjoy, and happy anniversary, Jimmo.
I'd been to other physical therapy offices before, and I'd really noticed I'd do my 10 or 20 appointments, and then I'd have to wait 6 months to get more appointments, and I would really notice that I would get worse during that time. Whereas when we're coming here consistently, it's much better at maintaining progress. MS is such a unpredictable disease that you can't really compare yourself to where you'd be without it, but I know for sure that I wouldn't be able to still do some things I can do. I use a wheelchair full time, but I can still mostly be independent.
I've been to a lot of inpatient and outpatient PT rehab places, and it's not like here at all. They treat you for whatever's going on. Oh, I have a foot drop, or I sprained my ankle. It's very short term, and it's not looking at the whole person. So this is a very unique model. I've never seen anything like this, where I can go to rehab, had the same therapist. Chris, the director here, has been literally working with me for 6.5 years. You don't have relationships like that with physical therapists in the community.
I had been asking for years to have a physical therapy referral, and no one was really prepared for MS patients. In fact, I had several centers say I couldn't do work there because I had MS. Keeping up with physical activity and a guided program like they offer here is really essential. I think anytime that I've taken a break for reasons of illness or something else going on in my life, I've always had to build back up. But if I maintain, it really keeps me much better.
If I didn't come here, I think I'd be in a wheelchair at this point, and I think I would probably be a lot less mobile and a lot less active than I am. You could be proactive, and I think you have to be proactive, otherwise I think the illness takes its toll. I believe that if I had been limited to 10 sessions or 15 sessions, that I would have just gone straight downhill afterwards.
I honestly and truly believe that I would be in a wheelchair if it wasn't for the MS Specialty Center and all the amazing people that work here. I absolutely would be. I am so thankful to everyone that works here. Even my fellow patients, we all kind of keep each other going. I really think that this is the most amazing place.
As I said, bear with us as we go through some of these changes. Thank you. Now, as we see Sam come up, I'll welcome any of our panelists up to join us for Q&A. Thanks, Judy.
And Scott, let's move to the next slide, maybe to the slide at the end with our with the center's information about reaching us. And then I'll introduce folks and we'll take a few minutes to see. There you go. That's great. Thank you.
Yep, folks are coming up. I'll just request everybody's camera here. Anybody that's interested, please do join us. Thank you for those who did stick around, both in terms of panelists and attendees.
Yes, and I, you know, we were a little bit enthusiastic, and with the technical issues, we had a little bit of going over time, but I thank you all so much for your time. As we can tell, we've got the full range of folks that are necessary to make our best effort to get care that people need. And I'm so grateful to Lynn and Lou for telling their stories, and Suzanne for helping so many people with multiple sclerosis. So Matt, do we have questions from that you've curated, and maybe you'll give us a shot with them, and then we'll also want to talk about the fact that we want to follow up and take, if you will, advantage of this coalition to move Jimmo forward. Thank you to my team for giving up your little bit of your time to answer questions rather than give your presentations. We'll do that yet. Okay, thank you. Go ahead, Matt.
Yep, as you might imagine, we have one or two questions here. There are a couple questions that many people asked in the chat.
Let's do those, yes.
And Renee, I think, touched on this a little bit, but a lot of people want to know, does this apply to Medicare Advantage plans? And related, difference between maintenance coverage in Part A versus Part B.
Okay, I'll tackle that a bit, and I'll ask if anyone else wants to join. Yes, in theory, in law, Medicare Advantage plans are required to provide at least as much coverage as what we'll call traditional Medicare. There should be, and the Jimmo settlement, Michael, I see you shaking your head, definitely applies to Medicare Advantage. Yet we hear from Dennis, who showed all the success he's had with Jimmo, how it's been much harder with Medicare Advantage. That should not be the case, but we know it is. And we have to make that known as part of our follow-on action to this presentation today with policymakers and with the media. Does anyone else want to chime in? Any disagreement or gloss on that? And then as to Part A and Part B, it's a payment model as to whether the payment is coming from Part A, which would normally be the case if you're getting coverage for the entire care in a skilled nursing facility. And for the first 100 visits of care in a home health setting, and then the next visits after that would be paid for by Part B. But the Jimmo settlement applies to therapy provided under both Part A or Part B in the inpatient setting of SNF, home health, or an outpatient clinic. Any comments or additions from my colleagues? Hopefully that means that I didn't say anything wrong. Go ahead. We want to see how many we can get to. Yes, thank you.
Thanks. If I may, I'd like to read a comment. Anne, I'm not going to call you out by last name or anything, but Anne said this was an excellent webinar, and she was embarrassed to say that she did not know about this as a nurse and a patient advocate. She does now and is going to spread the word. This is a game changer. Further to the point that, come on, CMS.
Lisa, I'm so glad you joined us, Anne, and Michael, for your focus on the nursing component. Anything you want to add about the nursing component, Michael, or MA?
No, I think we covered everything. It was interesting for me to actually listen to all the stories that came after too. So I will say, Judy, that Jimmo relates to the coverage standard, like the legal standard for coverage. A lot of what we're hearing are related to access, issues related to getting access to the care. We didn't really directly address that. So,
and a lot of that has to do with the payment and other incentives. Kathy, you want to just briefly talk about what you know so well, for instance, in the home care setting, and maybe Toby briefly in the SNF setting.
Can I interrupt for just a moment?
Coverage.
Sorry,
Yes.
you just mentioned, Judy, payment. We had half a dozen people ask about value-based purchasing. This may be the law, but how is it affected by payment policies? So perfect.
Yeah, and I will say what we have found over the years of working with patients is that the Medicare policies are highly incentivized for people with short-term, excuse me, post-acute care needs, and for people with chronic and longer-term conditions, the payments, the auditing, the quality measures lean into improvement. And so part of this is asking CMS to look at everything through the lens of people with chronic and longer term impairments, and how do we make access to services better by enhancing all of the teaching, the auditing, the quality measures, the payments in a way that helps to remove the discriminatory problems with care that lean in toward the short-term post-acute care and not the chronic longer-term services.
Right, thank you. Those payment quality measures, auditing, all that should go to making sure that it should mesh with the coverage, right? Everything we're telling you about the coverage should be encouraged, not create disincentives from the payment. The payment model should encourage the coverage. Cindy and Ellen, as we have you, I know you may have to leave soon. Did you want to add to this at all, or anything else you were hoping to be able to get across, as providers so often are not heard as our allies?
I think, that the stories from the providers that were present today give us hope that there are programs that are embracing this better, and that advocacy is not only for the beneficiary, but to make sure that those resources are in the hands of the provider, and acknowledging that if you have a provider that absolutely refuses, go find another one, because they're out there that will do it.
Well, we need to find them. That is harder, as Lynn points out, and Lou, than one wishes. But thank you so much.
Well, and the only thing I would add to that is, again, that therapists must be advocates for our patients, right? So if our employer is saying you can't do this, or they get a denial, we need to make noise. And I think the group of people here on this call provide a lot of, resources for persons who are experiencing difficulty either with getting paid for it or with being able to provide it.
Yes, and perhaps one of our follow-ons is to understand, as Michael said, and the many questions said, that the payment, and as Kathy indicated, all the other incentives and disincentives that are involved with payment and auditing and quality measures, maybe that's what we ought to join together to pull attention as a coalition to policymakers and to CMS. And I know, Kathy, we talked about a sign-on letter, and I think that we will work with you all to see if we can get something together that we would all support, about that coverage needs to be incentivized by all these other issues, payment and the oversight.
Well, if I can just add to that briefly, Judy, I think that one of those opportunities is those open comment periods to rules and updates to rules in these settings, because very often there are little to no comments made with respect to the issue of how many of these measures focus on improvement and don't seem to incorporate or value stabilization. And when there's only one or two comments out of several hundred, I don't believe it gets CMS's attention. And I think that many believe that those have to come from providers, but comment periods can come from beneficiaries, from advocates, from anyone who is concerned about the implications of this. And so I think sometimes the lack of feedback about that leads CMS to believe it's not an issue, or not an issue that should be taken seriously. So I think that's an opportunity to pursue in formalizing and getting that noise Ellen mentioned louder in those formal comment periods.
Yes,
Yeah.
that's
One
absolutely
thing,
true. We know they count
well,
sometimes, and we
one
just
thing I
did
think,
provide comments regarding the home health and skilled nursing facility and tried to encourage our colleagues to do so. I'm
one
sorry.
point I want to make just real quick, Judy, is that I do believe that we kind of had a win this year because there's a new cross-setting function measure implemented across IRF, LTAC, SNF, and home health that measures whether or not people, yes, exceeded, but also whether they met their expected functional level. So it's measuring maintenance of the same level. In other words, the provider gets credit for maintaining that function. And so I think the more therapists are aware of that, the better.
That's very important, and perhaps you could send me directly something I may not know about that I would like to broadcast more fully.
Absolutely, be happy to.
Okay. Matt, anything, maybe another question that recognizes a group of questions? Then we'll have to close.
We did have several questions regarding proper documentation and also how to get a physician to write a proper order. We actually had somebody write in and explain that they had the physician send them a copy of what they were going to write, suggested language to add to that, and then sent it back to the physician. Any comments on documentation for maintenance care?
Cindy or Ellen?
I think Renee touched on it in her presentation. I mean, the issue is you have to be able to demonstrate why a therapist was involved. And that's probably our biggest deficit across the board, is it very much reads about the patient performed this, completed this, names, reps, distances, and all of that, and don't really speak to the clinical decision-making of why certain things were done, or the professional opinion of the person delivering care about was it successful or not successful and what modifications need to be made. So I think that's the biggest strategy, is looking at our documentation and can you see why a therapist was involved? Because when that's missing, now it just looks like repetitive activities that could be done by a layperson, a family member. That's where that interpretation comes from, because the decisioning piece isn't really there. And so we have to pay attention to that issue. But I think part of it is also owning that if I'm going to be providing maintenance therapy, then say that. Put that in the order, put that in the documentation, put it in the plan. Don't try to sneak it or hide it, or just think if you put the word maintain in the note 50 times, somehow that will mystify people and you'll get paid. It really has to be to that skill. And that's always been a challenge in therapy documentation outside of maintenance, let alone when you bring that into that. With the physician, I mean, typically those orders, unless you feel differently, Ellen, come through as, you know, physical therapy for, occupational therapy for, speech language for. The decision about whether or not this is a maintenance approach from the very beginning, or if we're going to transition, is really based on the clinical assessment findings. And so I would not expect the order to come initially from the doctor saying, go do maintenance. Even if it said that, I would hold pending the assessment to figure out if this truly is the appropriate course of care with this patient, and then communicate with the physician to have an appropriate order ultimately. But I wouldn't obsess that it has to come directly that way, or try to wordsmith it prior to doing the assessment.
Thank you. Thank you.
The only other thing I would add is very similar, and that's one reason why I mentioned, you know, especially in the skilled nursing facility, we must differentiate ourselves from restorative therapy. But I do think that the two can coexist with the documentation that supports what's going on up here, right? That's the hardest part to get down on the documentation, is what's going on in your head. Don't just document like you're watching a movie. The patient walked 300 feet, or the patient did this and that. but talk more about what's going on in your head and why you're doing the things that you're doing.
Thank you. And I think that people who heard Lou and heard Lynn speak today can get a sense of why skill matters, as Sam said. I thought that was one of the most, it should be obvious, but it's not, Sam, you know, to the decision makers out there who just say, well, the family could have done this, but you could have hurt someone like Lynn was hurt, or you could see the detriment to lose life for not having skilled therapy provided on an ongoing basis. Anyone on my team would like to chime in at this point? Okay, well, I want to thank you all so very much. Obviously, this was a very full symposium. And what we hope is that you will, those who are still in attendance and these wonderful presenters, thank you all. Please write to communications@Medicare Advocacy with comments and feedback and follow-up suggestions, because we will be doing action alerts from the center to all those who registered for this symposium today to keep this coalition alive and to let media and policymakers know that payment and an oversight measures must be there to get coverage, not to keep coverage and access to care from folks who need it for longer term and chronic conditions. I'm indebted to you all, and thank you all so very much. Matt, anything further?
Just some wrap up. Thank you, Judy. And just to let you know, communications@medicareadvocacy.org is not just a generic email. It's me. So you really are getting somebody.
You will be heard.
So thank you for staying on late, everybody, especially our panelists. Absolutely incredible group today. Really amazing information. We are going to send a recording link to everybody that registered today. We can send it to our panelists as well. And we will probably do some follow-up with the folks that mentioned in our questionnaire that they filled out ahead of today's symposium that who said they had more info to share and were willing to share it. We're going to be reaching out to you. If anybody online is interested, we do have a couple webinars coming up for the Christopher Dana Reeve Foundation regarding Medicare for veterans with paralysis, which will certainly overlap with the need for skilled maintenance care. And you can register for those at medicareadvocacy.org/webinars. You can also stay up to date on presentations and more by signing up for our CMA alert. I want to thank everybody once again, and I will now conclude today's presentation.
Thank you all. Thank you so much, Michael.